Advanced Concepts in Pediatric TB, sponsored by the Southeastern National TB Center. Today we present latent TB infection. The presenter is Dr. Nizar Maraka. Dr. Maraka is an assistant professor of pediatrics at the University of Florida College of Medicine, Jacksonville, and the fellowship program director for pediatric infectious diseases. He is a fellow of the Pediatric Infectious Diseases Society and practices as a specialist in pediatric infectious diseases at UF Health, Jacksonville, and Wolfson Children's Hospital, as well as the University of Florida Center for HIV/AIDS Research, Education and Services, UF Cares. Dr. Maraka graduated from the Faculty of Medicine at the University of Jordan in 1993, after which he completed his pediatric residency and infectious diseases fellowship at the University of Florida College of Medicine in Jacksonville. He's received many teaching awards during his career and has numerous publications to his credit. Without further ado, I will turn the microphone over to Dr. Maraka.
Dr. Maraka, we are not hearing you. You need to maybe unmute your phone by pressing *7. Somehow we are not hearing Dr. Maraka.
I hope everybody can hear me.
We are hearing you now. Great.
Okay, wonderful. So let's start with the objectives of this talk on latent TB infection. At the end of presentation, I hope that you'll be able to identify the high priority groups of children who should be tested for LTBI, should be able to understand the indications for tuberculin skin testing and the interferon gamma release assay test, and to correctly interpret these tests and describe the management of children with positive TST or IGRA. As I go through some instructional cases, I want you to think of two questions related to each of these cases. The first is a 7-year-old Hispanic male who moved to the U.S. from Guatemala 4 years ago, received the BCG vaccine at the age of 1 year, has a known contact with infectious TB case, and has a tuberculin skin test of 5 millimeters of induration. He has no symptoms of TB disease and a normal chest X-ray and laboratory test. We will come back to the cases and their discussions at the end of the presentation. The second case is a 12-year-old Asian female who moved to the U.S. from the Philippines more than 5 years ago, plans to volunteer at a long-term care facility, had a TST result that was negative, 0 millimeter induration 1 year ago, and a recent TST showed 26 millimeters of induration. Her chest X-ray is normal, she has no symptoms of TB disease, and no known contact with a TB patient. Our third case is a 16-year-old Asian male who moved to the U.S. from China less than 5 years ago, received BCG vaccine as an infant, has an IGRA test that is positive, a normal chest X-ray, no symptoms of TB disease, but is known to have contact with a TB patient. So what is latent TB infection? It is described as the presence of Mycobacterium tuberculosis organisms without signs or symptoms or radiographic or bacteriologic evidence of TB disease. Latency is a state of persistent mycobacteria T-cell responses in the absence of clinical evidence of disease. A lot of people think of it as an infection with Mycobacterium tuberculosis that is insufficient to produce clinically manifest disease. It is almost like an incubation period of undefined duration. The direct identification of latent TB infection is not possible That's why the best available proxy for diagnosing LTBI is the identification of an adaptive immune response by the available tests, tuberculin skin test and the interferon gamma release assays. In a consensus statement, the TBNet group questioned even this concept of latent TB, of whether it's due to infection with mycobacterial organisms that are viable, just a lasting immune response. And this is becoming an area of future research. It is important, however, to make a very important distinction between latent TB and TB disease. It shows some of these differences. In latent TB infection, a TST or IGRA test is usually positive. However, a chest X-ray is normal, and the patient has no symptoms or physical findings of TB disease. And if done, respiratory specimen bacteriologic studies are usually negative. This is in contrast to TB disease, the pulmonary TB being the most common of the manifestations. Targeted TB testing is an important strategy employed in the United States. As TB disease rates have decreased, finding and treating persons with high risk for LTBI has become a priority. Targeted TB testing is used to focus program activities and provider practices on groups at highest risk for TB. Treatment of LTBI substantially reduces the risk that persons infected with MTB will progress to TB disease. In fact, INH treatment has been shown in randomized studies to be as effective as 90 to 93% in preventing progression from TB infection to TB disease. For more than 3 decades, an essential component of TB prevention and control in the U.S. has been the treatment of persons with LTBI to prevent progression to TB disease. Essential TB prevention and control is this targeted TB testing policy. It detects persons with LTBI who would benefit from treatment, de-emphasize testing of groups that are not at high risk for TB, and can help reduce the waste of resources and prevent inappropriate treatment. Let's go over a couple of slides that show the milestones regarding LTBI and LTBI treatment. In 1965, the American Thoracic Society recommended treatment of LTBI for those who are previously untreated TB, have a TB skin test conversion, and young children. In 1974, the CDC and ATS established guidelines for pre-treatment screening to decrease the risk of hepatitis that was associated with treatment. Treatment was recommended for all persons 35 years or less. In 1983, the CDC recommends clinical and laboratory monitoring of persons 35 and older who require treatment of LTBI. And in 1988, the CDC recommended 2 months of rifampin combined with pyrazinamide as an option for HIV-infected patients. That later changed, as I will demonstrate. In 2000, the CDC and the ATS issued updated guidelines for targeted testing and LTBI treatment. That included the 9-month regimen of INH as the preferred regimen for treatment. Due to liver injury and death associated with 2-month regimen of rifampin and pyrazinamide, in 2001, the use of this option was de-emphasized in favor of the other regimens. And in fact, the rifampin pyrazinamide 2-month regimen is now not recommended, except to be used in cases where the potential benefits outweigh the risks of severe liver injury and death. And more recently, in 2011, the CDC recommends the 12-dose 3-month regimen of INH and rifapentin as an option equal to the standard 9-month INH regimen for certain groups of individuals, which we will come back to later in the presentation. So moving on, identifying risk factors for progression to TB disease once infected is crucial for the strategy of targeted TB testing. The risk of progression declines exponentially by about 10-fold over the first few years. It is highest in the first 1 to 2 years after acquisition of the infection. It is thought that the cumulative risk is 2 to 5% in the initial years after infection, 1 per 100 person years, and the subsequent risk falls down to 1 in 1,000 person years. The lifetime risk of an individual is approximately 10 to 15%, with the risk increasing substantially to 5 to 15% annually in the immune compromised, especially persons with infection with HIV. Persons at high risk of developing TB disease fall into 2 categories: those that have increased likelihood of exposure to persons with TB disease, and those with clinical conditions that increase their risk of progressing from LTBI to TB disease. Increased risk of progression from LTBI to TB disease is seen especially in children who are 5 years or younger with a positive TST. The risk is largest in the youngest children, and it drops to one of the lowest in life during primary school to increase again in adolescence to a second peak. Also at increased risk of progression from LTBI to TB disease are HIV-infected persons, those with a history of prior TB, untreated TB, or fibrotic lesions on chest X-ray. And also persons that are underweight or malnourished. I would like to point out here that recent converters, those are persons who have more than 10 millimeter increase in their TST size from baseline testing within a 2-year period, recent converters are also at a very high risk of progression from LTBI to TB disease. There's also an increased risk of progression for persons who are receiving tumor necrosis factor alpha antagonists, as well as other immunomodulators, including prolonged use of high doses of corticosteroids, injection drug users, and those with certain medical conditions such as chronic renal failure, hemodialysis, solid organ transplant recipients, diabetics, and other conditions are at increased risk of progression. As for the methods of detecting MTB infection, there are 2 that are available in the United States: the Tuberculin skin test and the interferon gamma release assays. Both of these test the adaptive immune response to MTB, and these tests do not exclude LTBI or TB disease. Thus, decisions about medical and public health management should include other information, physical examination, radiologic evaluation, and not rely solely on the TST or IGRA results. As for the tuberculin skin test, this is a test that's been continuously in use for over 100 years in clinical medicine. It's a skin test that measures delayed type hypersensitivity reaction to the purified protein derivative of tuberculin, a mixture of antigens that are shared by M. tuberculosis, Mycobacterium bovis, and Mycobacterium bovis BCG, as well as some other environmental mycobacteria. The multiple puncture tests, such as the Tyne test, are inaccurate and are not recommended for use. To administer the TST, we inject 0.1 ml of the PPD tuberculin solution intradermally on the volar surface of the forearm using a 27 gauge needle to produce a 6 to 10 millimeter wheel in diameter. This is called the Mantoux technique. To measure and read the TST, we usually measure an induration in 48 to 72 hours after placement by palpating and measuring the induration and not the erythema. We record the reaction in millimeters, not as negative or positive. Even if there is no reaction, we usually record 0 millimeters of induration. Highly professional and trained personnel should read the TST test, and it should not be read by patients or family members. A TST test that was not measured and recorded in millimeters of induration must be repeated. An induration, however, may start to appear immediately following TST placement, and that typically is due to a type 1 or type 3 immune reaction as opposed to the delayed type hypersensitivity reaction. From a histopathologic standpoint, there is extravasation of lymphocytes into the epidermis and interstitium at the site of administration. A strongly positive TST may lead to some persistent skin discoloration and rarely to tissue necrosis. You should educate the patient and the family regarding the significance of a positive TST result. In fact, an intention to test should be an intention to treat. Positive TST reactions can be measured accurately for up to 7 days. And I would like to point out here that a delayed reaction appearing beyond the 48 to 72 hours of placement is not uncommon in children and is much more likely to occur than in young adults and older individuals. However, negative reactions can be read accurately for only 72 hours after placement. To interpret the TST, cutoffs have been established based on the risks the patients have. A lower cutoff will result in a higher sensitivity and lower specificity for MTB infection. A cutoff of 5 millimeters of induration is interpreted as being positive for HIV-infected persons, those who have had close recent contacts of infectious TB, persons with chest radiographs consistent with prior untreated TB, organ transplant recipients, and other immunosuppressed patients. A 10 millimeter induration cutoff is used for recent arrivals from high prevalence countries, children under 4 years of age, persons with clinical conditions that place them at high risk of progressing to TB disease, residents or employees of congregate settings, injection drug users, and laboratory personnel at high risk. A 15 millimeter induration is the cutoff used for persons who have no risk factors. And although skin testing programs should only be conducted among the high-risk individuals, certain persons may require TST testing for employment or school attendance and other reasons. Diagnostic interpretation and treatment of LTBI should always be tied to risk assessments. And there are risk assessment tools that are suggested by the CDC as well as the American Academy of Pediatrics, available in the Red Book and at their website. Factors that may cause a false positive tuberculin skin test reaction include non-tuberculous mycobacteria. Environmental mycobacteria typically may cause a reaction that is usually less than 10 millimeters of induration, although overlap may occur and you may see higher degrees of induration. BCG vaccination is the other important cause of a false positive TST reaction. A BCG usually leaves an immunological imprint for prolonged periods of time. However, it is positive in less than 5% after 5 years of placement. In only a few, it may be positive for up to 10 years after placement. Reactivity of BCG vaccine recipients generally wanes over time, and so a positive TST result is likely to be due to TB infection if factors are present. Causes of false negative TST reactions include anergy, which is the inability to react to the TST because of a weakened immune system. The usefulness of anergy testing in patients who are infected with HIV have not been established and is not routinely recommended. Other causes of negative TST include a recent TB infection, as it usually takes 8 to 10 weeks for the delayed type hypersensitivity response to become apparent. Overwhelming TB disease is another cause of false negative TST reaction, especially miliary TB and meningitis. And the very young, especially the early infancy and neonatal age. I would like to mention here that a negative TST may not be reliable at this very young age, but a positive test is very useful when investigating newborns, neonates, and infants. A full TB investigation typically is warranted in these situations, and prompt treatment should be started as directed by the results of that investigation. A TST usually is repeated in a negative initial test 8 to 10 weeks later, and that should provide more reliability of the TST test in those with very young age. Other causes of false negative TST reaction include a live viral vaccination, which can temporarily suppress TST reactivity. The example we face frequently is the placement of an MMR, and also poor TST administration technique. Another phenomenon to take into account is boosting. Some people with LTBI may have a negative skin test reaction due to the waning response. An initial skin test may cause a boosting of the ability to react to tuberculin. So subsequent positive or boosted reactions to TST may be misinterpreted as being a new infection. Boosting may also occur with individuals who received BCG vaccine. So two-step testing is a strategy used to detect those who have boosting. It's a strategy used to differentiate between a boosted reaction and a reaction due to a recent infection. We use the two-step testing for initial baseline testing for adults who will be retested periodically, such as healthcare workers. And as this diagram shows, the baseline skin test, when negative, should be repeated 1 to 3 weeks later. And if the repeat test shows to be positive, then the reaction is considered to be a boosted reaction due to a TB infection that might have occurred a long time ago. Those individuals require follow-up of their positive TST and evaluation for LTBI treatment. For patients who are pregnant, TST is safe and reliable for a mother and the fetus throughout pregnancy. A pregnant woman who has risk factors for TB infection should undergo TST skin testing. As for occupational exposure, such as in healthcare workers, the cutoff for TST positivity usually depends on the prevalence of TB in the facility and the individual's own risk factors for TB. It is typically recommended to test at higher and at intervals that are determined by the annual risk assessment. Now we come to discussing interferon gamma release assays. These are ex vivo whole blood tests that are used to detect the immune response to MTB infection. There are 2 US FDA-approved IGRAs that are commercially available: the QuantiFERON TB Gold in Tube test and the T-Spot TB test. Both of these are tests that measure and compare the amount of interferon gamma release by blood cells in response to antigen stimulation. It entails mixing blood samples with antigens from Mycobacterium tuberculosis as well as controls. The T cells that recognize these antigens release interferon gamma, and it's measured by an immunospot or a whole blood ELISA technique, depending on the test used. The amount of interferon released in response to MTB is compared to the amount released in response to other antigens and to background signals, positive and negative controls. The results are usually reported as either positive, negative, or indeterminate, or borderline. It is important to note that laboratories should provide both quantitative and qualitative results of the IGRA test. These quantitative results may be useful for cases in combination with risk factors. The advantages of these IGRA tests is that they require a single patient visit to conduct the test, and these results are available typically within 24 hours. IGRAs do not boost response by subsequent tests, and they have a much higher specificity than TST in populations with higher prevalence of BCG vaccine, since BCG vaccination does not cause false positive IGRA test results. There are very few environmental non-tubercular mycobacteria species that can cause a false positive IGRA. These include Mycobacterium kansisi and Mycobacterium marinum. The disadvantages or limitations include errors in collecting and transporting the blood or in interpreting the assays, which can decrease the accuracy of the IGRA test. The tests may be expensive, and there is very limited data on the use of IGRAs for children less than 5 years of age, persons who have been recently exposed to TB, the immunocompromised persons, including HIV-infected individuals, although we now know that IGRAs seem to have a higher sensitivity than TST population, and also for those individuals who require serial testing. There is limited data on the use of IGRAs to predict who will progress to TB disease in the future. So a question that comes up is which TB test to select. A simple way is to consider that IGRAs are the preferred method of testing for groups of people who have poor rates of returning for TST to be read, and also for persons who have received a BCG vaccine. However, TST is still the preferred method for testing children who are under 5 years of age, until more data is available about the reliability of IGRA in that age group. Either test can be used without preference for other groups that are tested for LTBI, and the routine testing with both TST and IGRAs is not currently recommended. However, results from both of those tests may be helpful when the initial test is negative and the patient has high risk of TB infection or disease, when the initial test is positive and additional evidence is required or desired, and also when the initial test is either unclear or indeterminate. In cases of contact investigations, you should confirm a negative test via retesting 8 to 10 weeks post-exposure, and it is recommended that you use the same test for repeat testing to reduce misclassification errors. If positive contacts provide written documentation of a prior treatment for latent TB infection, they usually do not need to be retreated. Retreatment is only indicated if those individuals have a very high risk of progressing from LTBI to TB disease, such as being severely immunocompromised. Close contacts with negative TB test results should be evaluated and treated for LTBI if they are under 4 years of age, if they are immunosuppressed, and if any person who has a high risk of progressing from TB disease once they get infected. Children who are less than 5 years of age are at particular risk of progressing from LTBI to TB disease, and that is why window prophylaxis should be provided until they get retesting 8 to 10 weeks after the last exposure. Now we come to the LTBI treatment regimens. It is crucial and important to remember that you have to rule out TB disease before embarking on treating latent TB infection by performing an extended history, doing a good physical examination, and a chest radiograph. When indicated, bacteriologic studies should be used to rule out TB disease. Ruling out TB disease is helpful to prevent undertreating TB and contributing to the problem of resistant tuberculosis. You should determine prior history of treatment for LTBI or TB disease, the risks and benefits of treatment, which we will allude to in a minute, and determine the current and previous drug therapy, as well as recommend HIV testing to individuals who have TB infection. The regimens used for latent TB infection include the standard 9-month regimen of isoniazid administered daily or twice weekly by direct observed therapy. It also includes INH rifampin 3-month regimen given once weekly for 12 doses, and rifampin given 4 months for adults and 6 months as recommended by the American Academy of Pediatrics for all children on a daily basis. It is important to remember that the regimens need to be completed within 12 months for the 9-month INH regimen and within 4 months for the INH rifampin 3-month regimen. As for the standard 9-month INH regimen, this is the preferred regimen for children 2 to 11 years of age. A 6-month INH regimen is less effective, but may be used if the child is not able to complete 9 months. The efficacy drops from 93% for the 9-month regimen to around 69% for a 6-month INH regimen. INH needs to be given daily or intermittently and administered with direct observed preventive therapy when administered intermittently. The number of doses to be completed within the 12 months include 270 doses in 9 months of therapy. The second regimen that is recommended is INH and rifampin, which is a 3-month regimen given as an option equal to the 9-month INH regimen for treating LTBI in otherwise healthy people who are 12 years of age or older and have recently been diagnosed with LTBI. You must use direct observed therapy for the INH rifampin regimen. It has been approved for individuals who are between the ages of 2 and 11 years if completion of the 9-month INH regimen is either unlikely and also if the hazard for TB disease is great. It is not recommended for children younger than 12 years of age routinely. It is not recommended for HIV-infected individuals who are taking antiretroviral therapy and for pregnant women or women who may become pregnant within this 12-week regimen. INH and rifampin is usually administered once a week for 3 months in 12 doses by direct observed therapy within a 4-month period. As for rifampin regimen of 6 months administered daily for children is an acceptable alternative to treat LTBI. In situations where rifampin cannot be used, as in HIV-infected persons, rifabutin may be substituted. The regimen for children comprises of 180 doses administered over a 6-month period on a daily basis. In certain situations, such as HIV-infected persons, you should consult an expert who is an expert in managing HIV and TB. INH 9 months rather than 6 months is optimal for treatment. Rifampin typically is contraindicated for persons who are taking most antiretroviral regimens, and rifabutin can be sometimes substituted for rifampin with certain dosage adjustments. The INH rifapentin regimen is not recommended when the HIV infected individual is receiving antiretroviral therapy. Persons who have fibrotic lesions suggestive of previous TB should be treated when they have a positive TST reaction, at least 5 millimeters of induration, or an IGRA test that is positive, and when they have no symptoms of infectious disease and no history of treatment of TB disease. You treat only after active disease is excluded with bacteriologic sputum testing. For contacts of persons with multidrug-resistant TB, you should consider the risk of progressing from MDR to MDR TB disease before you commence treatment for LTBI. Typically, an expert in the treatment of MDR TB should be consulted, as these treatment regimens are complex. A dual agent regimen is typically used, to which the MTB is susceptible, and we typically use second-line agents for this treatment regimen for a longer duration of time, and typically a close monitoring of the patient and regular follow-up is mandatory and is extended for a longer period of time. In cases of pregnancy, some experts prefer delaying treatment until the early postpartum period, unless the pregnant woman is at high risk of progression to TB disease, such as having an HIV infection or being recently infected with TB and having a high risk of progression to TB disease. A 9-month regimen of INH administered daily or twice weekly is recommended with supplementation with vitamin B6. Pregnant women should be monitored closely as they have a higher chance of developing adverse reactions to the INH. Breastfeeding is not a contraindication, and in fact, vitamin B supplementation is recommended for nursing women and for breastfed infants who are receiving the INH regimen. For transplant candidates and recipients with latent TB infection, it is sometimes challenging to make the diagnosis as well as to undergo treatment for TB due to the substantial interactions that occur between the TB drugs and the immunosuppressive medications. A risk assessment in the transplant recipients for developing TB depends, among other factors, on the local expected underlying prevalence of infection. In areas of high prevalence, preventing TB with chemotherapy to all transplant recipients is justified, and in medium to low prevalence areas, preventive chemotherapy should only be offered to those whose tests are positive for TB infection. One should ensure the completion of therapy based on the total number of doses for the regimen used and not on the duration alone. How do we manage patients who have missed doses? It is important to extend or restart the treatment if interruptions occur and they were frequent or prolonged enough to preclude the completion of the number of doses within the recommended duration. When treatment has been interrupted for more than 2 months, patients should be examined to rule out TB disease, and direct observed preventive therapy may be recommended as needed in these individuals. Monitoring of drug treatment is another important element in treating LTBIs. You have to educate the patient to report signs and symptoms of adverse reactions. These include fever, headache, rashes, anorexia, nausea, vomiting, and abdominal pain indicating the possibility of hepatotoxicity, fatigue or weakness, dark urine, and persistent numbness in the hands and feet indicating peripheral neuropathy. Peripheral neuropathy, which is associated with INH use, tends to occur in less than 0.2% of recipients, and it tends to occur more likely in individuals who have other neuropathic conditions such as diabetes, HIV, and alcoholism. Monthly visits are recommended in patients placed on LTBI regimens with a brief physical examination and a review with the patient and family of the rationale for treatment, adherence with therapy, symptoms and signs of adverse drug reactions, and the plans for continued treatment. The incidence of clinical hepatitis in persons taking INH is quite low and lower than previously thought. It can be as low as 0.1%. Hepatitis risk increases with age. It's uncommon in persons who are under 20, and nearly 2% of persons who are between 50 and 64 years of age may develop hepatitis. The risk increases with people who have underlying liver disease and who have heavy alcohol consumption. In a recent study published in the Journal of the Pediatric Infectious Disease Society, Chang and colleagues looked at the hepatotoxicity in people receiving INH. In 1,235 children who received 9 months of INH, 13 developed hepatotoxicity. 8 were girls and 9 were Hispanics. 11 of those 13 had symptoms and signs, and only 2 were asymptomatic, with an ALT elevation more than 5 times the upper limit of normal. 3 developed hepatotoxicity more than 6 months after the start of INH. ALT and liver enzymes dropped back to normal in all the patients after stopping INH. The authors concluded that INH hepatotoxicity occurred at a very low frequency and is typically reversible when INH is stopped. Evidence of the occurrence of late drug-induced liver injury is quite important and emphasizes the importance of monitoring for symptoms as well as transaminase levels throughout INH therapy in children. Baseline laboratory monitoring is not necessary on a routine basis except for patients who have risk factors, such as those mentioned on this slide. Repeat laboratory monitoring should be performed in people with abnormal liver functions and baseline studies, those who have high risk for adverse reactions or develop symptoms or signs suggestive of an adverse reaction, and for the current or recently pregnant. Asymptomatic elevation of liver enzymes is seen in 10 to 20% of people taking isoniazid. The levels usually return to normal after the completion of therapy. You should discontinue INH treatment if transaminase levels are 3 or more times the upper limit of normal when patients have symptoms, and 5 or more the upper limit of normal if the patient is asymptomatic. To meet the challenges of TB prevention, for every patient we should assess the TB risk factors. If risk is present, you should perform the appropriate testing, and if TST or IGRA is positive, you should rule out TB disease. If TB disease is ruled out, then one can initiate treatment for LTBI, and once treatment is initiated, you should ensure the completion of treatment, and then finally document and educate the patient about their management of LTBI. I've included in your handout some additional resources for future reference. Going back to the instructional cases quickly, our first case was a 7-year-old Hispanic male who had moved to the U.S. from Bolivia 4 years ago, received a BCG vaccine at the age of 1 year, had known contact with an infectious TB case, a TST 5 millimeter of induration, no symptoms of TB disease, and a normal chest X-ray, CBC, AST, and bilirubin. The questions we're asking is what's the patient's risk factors for TB infection or disease, and what's the appropriate management? Regarding the risk factors, this is a patient who is a contact of an infectious TB case, a recent immigrant to the U.S. from a country with high prevalence within 5 years of immigration. If the patient had not been a contact, the recent immigration within 5 years would have made him a candidate for targeted TB testing, but 5 millimeter reaction would not be considered positive. Since he had been in contact with an active TB case, the 5 millimeter of induration is considered a positive reaction, and this patient should be treated for LTBI immediately. The second case was of a 12-year-old Asian female from the Philippines who moved to the U.S. more than 5 years ago and who had a TST negative reaction 1 year ago and now has another TST for volunteering that is at 26 millimeters of induration. Her chest X-ray was normal, no symptoms of TB disease, and no known contact of TB patients. In discussing the risk and management for this patient, this is what we call a TST recent converter because she converted from a negative reaction to a positive reaction within 2 years of placement of the baseline testing, and it was an increase by more than 10 millimeters of induration. These individuals who are recent TST converters are at a very high risk of progressing from LTBI to TB disease. Her foreign-born status is less of a risk factor since she immigrated to the U.S. more than 5 years ago. She is a candidate for treatment of LTBI with INH. Our last case was a 16-year-old male who moved to the U.S. from China less than 5 years ago and received a BCG vaccine in China as an infant. IGRA test was positive, chest X-ray was normal, and he had no symptoms of TB disease. He is a known contact with a TB patient. For this patient, his positive IGRA suggests that MTB infection is very likely. The result is not affected by his prior BCG vaccine and should not be attributed to that. A recent migration to the U.S. from a country with a high prevalence of TB within 5 years is another risk factor. His foreign-born status thus is a risk factor for TB infection, and he is a known contact with a TB patient. Thus, this recent immigrant from a TB endemic area with a positive IGRA result is typically indicative of LTBI. Contact with the TB patient could have been his source of infection, and he should be treated for LTBI. I would like to thank you for your attention, and I want to also thank Dr. Alvarez for monitoring the questions that you guys have forwarded, and ask her to join us and hopefully be able to answer some of those questions.
Thank you, Nisar. You got several questions, so I'm going to try to go through this quickly. Some of the questions are regarding the actual administration of TST. So one of the questions is if when it is administered, there is no wheel, do you have to repeat the test?
Typically, if a wheel is not produced, then it is very likely that the TST administration technique was not done appropriately, and so that test needs to be repeated. And it usually it's recommended that you repeat the test in an area that is a little bit away from the site of the initial attempt at placement, so that there is no confusion with the reading of the TST and its interpretation.
Okay, thank you.
Thank you.
So the other question is if it is a low risk person and was tested, we don't know why, but was tested and had a 0 millimeter reaction, and then get retested and has a 7 millimeter reaction, it is, according to what you said, considered negative, but do you know what happened to produce that reaction?
That's a good question. So it is well known that reactions in persons who have no risk factors are likely to be false positive reactions when it comes to TB infection. Those reactions can be produced by non-environmental mycobacteria. They can also be boosted, as the situation is with MTB itself and with BCG. So even non-tuberculous mycobacteria can cause a little bit of a booster reaction to explain why the initial test might have been negative and the repeat test showed a 7 millimeter in duration. But you should apply the risk factor cutoffs on interpretation of the TST result regardless.
Okay, okay. So if a person has a positive TST, should that person be ever tested again with a TST?
So a positive TST is well known that it may wane with time. However, there is no reason to repeat a TST in somebody who previously had a positive TST and potentially diagnosed with a latent TB infection, because the repeat test is likely to stay positive, and not everybody's reaction wanes over time in the same fashion.
Okay.
I hope that answered the question.
I think so.
Okay.
Okay. Another question is, so a person that works in a refugee clinic gets this question. It is a requirement that the children that are under 5 have a PPD placed. Many of these children have received BCG and have no history of contact. They're thriving and they're asymptomatic, have normal chest x-rays, but have positive PPDs. How would you approach these children?
All right, so there are a few things to mention regarding this question. The first is the fact that if these children are coming to a refugee clinic, typically from areas with high endemicity for TB, then they, by definition, are at high risk. The second point is that you should really interpret the PPD regardless of the history of BCG placement, since most individuals will have a negative TST 5 years from the placement of the BCG, and that's due to the waning response, as we mentioned. So for those individuals, they should be evaluated and managed as potentially latently TB infected. We are not able to use the IGRA in this population just because of the lack of evidence for their reliability in this age group. But that is the setting that we would hope future generations of these IGRA tests would become helpful to weed out the population that received the BCG and could potentially have a TST reaction that could be attributable to the fact that they received the BCG.
Yeah, this is a very, very common scenario. Now, some of these kids actually come to the clinic and they have had a positive PPD, and they, not necessarily in the refugee clinics, but by other physicians, have had an IGRA test done. So let's say they're immigrants, let's just 5 years of age, and have a positive PPD and a negative IGRA. Would that change your management?
That's a very good question, and it's an area that we see ourselves faced with more and more. Again, the IGRA in someone who is less than 4 years of age is not backed up by sufficient data from clinical studies to be reliable enough to change my management. In fact, when TST or an IGRA, either of those is positive in that population, in the child who has a risk factor, such as the immigrant or G, I would still that individual has LTBI and should be evaluated and managed for that.
Okay. I have another question about this test in children less than 2 years of age. If children that are less than 2 years of age have been exposed to an infectious case and have been negative, have been tested negative by TST initially, and then 2 weeks after 2 weeks of the exposure, do they need to be retested every 6 months?
No, well, the recommendation is to repeat that testing 10 weeks the last known exposure. And so there is really no reason to repeat test them every 6 months or later serial testing if the contact to which they, were exposed is managed appropriately and is no longer a source of potential new infection. So they basically would receive the repeat testing 8 to 10 weeks from the initial, and once that repeat testing is found to be negative, if they had received window prophylaxis, then the window prophylaxis can be stopped and they would not require to complete treatment for latent TB infection.
Yes, thank you. I agree with that. One question that is important, we're kind of getting to the end, but let me see if we can at least get this one. Okay, do you know how long does it take for positive IGRA test in a confirmed case of TB to revert negative when the patient is being treated or has finished treatment?
That's a very good question, and it really, we know that the IGRA response wanes with time. So even if not treated, there is a waning response after infection for the gamma interferon release. However, I don't think that there is a whole lot of information about the average time that it takes for IGRA to revert to negative after proper treatment of a TB infection. I don't know, Dr. Alvarez, do you know of any recent information on that?
No, I mean, we know that actually a good percentage of people that are treated by the end of their treatment, they're negative, but not everybody is negative. So it is possible, it's possible to continue to test positive. So it's lower, the result is lower. But because of that, it's not really recommended now to use IGRA for monitoring to treatment or if the treatment is adequate. There are other factors that you take into account, and it's not the recommendation to repeat IGRAs on these patients to follow up that when they can stop treatment.
Yes, thank you.
Okay, so one question. You said that in children, the duration of therapy, if they're treating with rifampin, is 6 months instead of the 4 months that is recommended for adults. Do you know what the cutoff age for that recommendation is?
Actually, I'm not aware of a cutoff age, but I know that it is recommended to do that for children, and it's an AAP recommendation that is been there for a while and is present in the Red Book. I'm not sure if there is an actual cutoff. We typically, I mean, consider children somewhere. Some people say 16 and others say 18. Do you know of a specific cutoff that's in that recommendation?
No, the AAP doesn't actually give a specific cutoff age, but what we usually do in general is once they reach puberty, so post-pubertal adolescents, are actually treated more as adults. So that's what I would use for a cutoff for that, is actually post-pubertal, an age, but more like a maturity, a stage of maturity.
Thank you.
Okay, well, we have a lot more questions, but we are have run out of time. I want to thank everybody for their participation or for very interesting questions. And I want to remind you that the next event is scheduled for October 23rd. It's not the second Thursday, but it's different. It's the 23rd at 12 o'clock. So, and I hope that you guys continue to attend. As we build on these webinars, the information will cover things that have covered already, but in more depth in many cases. And so I hope you can continue participating in the future webinars. Thank you.